Welcome to Board Pearls. This is episode 2 of 3 of the Autoimmune and Cholestatic Liver Diseases chapter in the Liver Disease module. This episode is primary biliary cholangitis, the mitochondrial antibody-positive cholestatic disease of the middle-aged woman, the prognostic scores, ursodeoxycholic acid first line, the second-line landscape after obeticholic acid left the market, and the stepped management of pruritus. The patient is almost always a woman in her 40s or 50s, with cholestatic liver tests. The alkaline phosphatase up, the transaminases mildly elevated and staying under 5 times normal, and the bilirubin normal or barely elevated, who is fatigued, itches at night, and has dry eyes or an associated autoimmune condition. That cluster, in that demographic, is primary biliary cholangitis until proven otherwise. The disease is the slow autoimmune destruction of the small intralobular bile ducts, where T cells attack the cholangiocyte and produce a non-suppurative cholangitis that progresses over years through ductopenia to biliary fibrosis, and the antigen is a subunit of pyruvate dehydrogenase on the inner mitochondrial membrane, which is why the diagnostic antibody is the anti-mitochondrial antibody. It's female predominant, roughly 9 or 10 to 1. The diagnosis is made on labs alone in the great majority of patients: a positive mitochondrial antibody, an alkaline phosphatase above 1.5 times normal, and transaminases under 5 times normal, with no alternative explanation, gives a very high predictive value and makes biopsy unnecessary, so the candidate who orders a biopsy in a fatigued middle-aged woman with cholestatic labs and a positive antibody has added cost and risk without changing the diagnosis. 2 scenarios bend that rule. The first is antibody-negative disease, a small fraction of cases, which has the same syndrome and the same response to therapy, but needs a biopsy to lock down the diagnosis. Or testing for the alternative antibodies, which are specific but insensitive, so a negative test doesn't rule it out. The second is the inverse, a positive antibody with normal liver tests in a well patient, which is rare and only progresses in a minority, so the move is periodic monitoring of the liver chemistries rather than a workup or biopsy. When biopsy is performed, the diagnostic lesion is the florid duct lesion, granulomatous lymphocytic destruction of a small bile duct, essentially pathognomonic and appearing at any stage, and the staging system walks from that lesion through ductular reaction and bridging fibrosis to cirrhosis, with earlier stage predicting better response. The natural history without treatment is biphasic, a long asymptomatic phase of silent progressive fibrosis, roughly a couple of decades, followed by a shorter symptomatic phase from symptom onset to death from cirrhosis complications. The key insight is that the rate of progression tracks directly with the serum alkaline phosphatase and bilirubin, so even modest elevations of alkaline phosphatase carry progression risk, which is the entire reason biochemical targets, not symptoms, drive treatment decisions, because those numbers are the surrogate for survival. 2 continuous risk scores formalize this, and the boards expect them by name. One combining age, bilirubin, alkaline phosphatase, albumin, and platelets a year after starting ursodeoxycholic acid to predict transplant-free survival, and another using a similar set to predict liver-related death or transplant, both calculated after 12 months, both stratifying along a continuous risk gradient rather than a binary response, and both use the same way to identify the patient whose biochemistry at 12 months predicts a poor trajectory. So, ursodeoxycholic acid is the universal first-line therapy, and the mechanism is partly bile acid replacement and partly cytoprotection. It's a hydrophilic bile acid that competitively replaces the toxic hydrophobic native pool, stabilizes hepatocyte and cholangiocyte membranes against that detergent injury, and stimulates protective bicarbonate secretion at the cholangiocyte surface, with mild anti-apoptotic and immunomodulatory effects on top. The dose is 13 to 15 milligrams per kilogram per day, continued lifelong, and it slows histologic progression, lowers the alkaline phosphatase, and improves transplant-free survival in responders to a level approaching the general population, with about 2/3 of patients responding. The third who don't respond are the consequential group, at meaningfully higher risk for cirrhosis, transplant, and death, and they need a second drug. Response is assessed at 12 months, and while several criteria sets exist, the unifying claim is simple. The alkaline phosphatase should have come down toward 1.5 times normal at 1 year, and the bilirubin should have stayed normal. And if neither has happened, the patient is on a steeper trajectory and needs a second agent, with intolerance also an escalation trigger. The early stage criteria define response as the alkaline phosphatase and transaminases under 1.5 times normal with a normal bilirubin, and the named scores express the same risk continuously. The second-line landscape changed in the last couple of years, and you have to know where it stands now. Obeticholic acid was the first second-line agent, a farnesoid X receptor agonist that reduces bile acid synthesis with anti-inflammatory and anti-fibrotic effects, but it was withdrawn from the U.S. market in 2025 for ongoing liver injury signals and is no longer an available option, so the mechanism is worth remembering because that receptor biology appears in other liver content. But the drug itself isn't the answer to a current management vignette. That leaves elafibranor and seladelpar, both peroxisome proliferator activated receptor agonists and the only second-line agents now on the U.S. market. Elafibranor activates PPAR alpha and delta, and seladelpar is more selective for PPAR delta, and in their trials in ursodeoxycholic acid non-responders, roughly half to two-thirds hit the composite biochemical endpoint at 12 months versus few on placebo, with a meaningful share achieving normalization of the alkaline phosphatase. The teaching point that organizes both is the mechanism. These agents modulate bile acid synthesis, transport, and cholangiocyte signaling in a way that lowers the alkaline phosphatase without driving the cholestatic pruritus that farnesoid X receptor activation produced, and in fact, they tend to improve the itch, which is a real advantage over the drug they replaced. The choice between them is driven by tolerability rather than a clear efficacy difference, with bezafibrate behind them as the European off-label option and fenofibrate sometimes used, with caution in cirrhosis. A few adjuncts complete the picture. Fat-soluble vitamin replacement becomes necessary as cholestasis advances, because the intraluminal bile acids drop below the level needed for micellar absorption, so you replace the fat-soluble vitamins. Bone density is checked at diagnosis and periodically, with bisphosphonates for established osteoporosis and adequate calcium and vitamin D in everyone. And the hyperlipidemia of this disease is dominated by an unusual lipoprotein and HDL, so despite striking total cholesterol elevations, the cardiovascular risk is generally not increased, and the profile is not atherogenic, so statins are safe but not mandatory unless conventional risk factors are present. And the candidate who reflexively adds a statin for a high total cholesterol in an otherwise low-risk patient has misread the lipid profile. Pruritus runs its own algorithm and deserves its own pass because it's the most distinctive symptom, frequently precedes biochemical disease, and disables patients in a way fatigue often doesn't. The itch is worst at night, often improves paradoxically as cirrhosis advances, and is generalized rather than dermatomal, with a multifactorial mechanism implicating retained bile acids, a lysophospholipid pyridogen, and endogenous opioids that potentiate central itch, and severe refractory pruritus is a standalone indication for transplant evaluation. The sequence is mechanism-targeted and stepped. Cholestyramine is first line, the bile acid sequestrant that binds bile acids in the lumen and lowers the recirculating pool, dosed up to 16 grams a day, with the testable piece being timing, because it binds many other oral drugs including ursodeoxycholic acid, levothyroxine, and the fat-soluble vitamins. So it's given at least an hour before or 4 hours after any other medication, with relief in days to a couple of weeks, and tolerance limited by constipation and the gritty preparation, with cholestyramine and cholestyramine as alternatives. Rifampin is second line for cholestyramine failures, working through a different mechanism, inducing hepatic enzymes and altering the microbiota to reduce production of pruritigenic secondary bile acids, dosed low and titrated, with most patients responding. But the narrow therapeutic window matters, because idiosyncratic hepatotoxicity occurs in the first couple of months and can be severe. So liver tests are checked at 4 to 8 weeks, and the drug is stopped at any signal of worsening transaminases or rising bilirubin. And the favored vignette is the patient a month into rifampin, whose itch has improved, but whose transaminases have risen sharply, where the answer is to stop the drug and watch the tests recover, not to reduce the dose and continue. Sertraline is third line, working through central serotonergic modulation, favored when depression coexists, which is common given the chronic illness and disrupted sleep. Naltrexone is fourth line, exploiting the role of endogenous opioids in central itch. Started low because some patients develop an opioid withdrawal-like syndrome within hours of the first dose, self-limited over about a week, which is the named complication the boards highlight, and which low-dose initiation mitigates. Fibrates sit in this sequence too, improving both the itch and the alkaline phosphatase, a meaningful contrast with what obeticholic acid did. And the newest mechanism-targeted class is the ileobile acid transporter inhibitors, which block the terminal ileum transporter that normally recovers bile acids increasing fecal loss and shrinking the recirculating pool, with a couple already approved for pediatric cholestatic pruritus and adult trials in late phase, so recognize the class as the emerging option for refractory itch. With secretory diarrhea, the dose-limiting effect since increasing fecal bile acid load is exactly what the drug does. Beyond medications, phototherapy, plasmapheresis, and albumin dialysis are reserved for highly refractory cases, and transplant is the definitive answer when the itch destroys quality of life. So the way of thinking is biochemical target-driven. Primary biliary cholangitis is diagnosed on the lab pattern plus the antibody and treated with ursodeoxycholic acid as a universal foundation, with escalation driven by where the alkaline phosphatase and bilirubin sit at 12 months, because those numbers are the surrogate for survival. The second-line landscape lost obeticholic acid, leaving alafibranor and seladelpar as the two approved PPAR-targeted agents, both of which tend to improve rather than worsen pruritus. And pruritus has its own mechanism-targeted sequence, from gut sequestration to enzyme and microbiota modulation with rifampin, to central modulators with sertraline and naltrexone, and on to the newer ileal transport blockade. The next episode turns to primary sclerosing cholangitis, the multifocal stricturing disease of the man with ulcerative colitis, where there's no proven medical therapy and the management centers on surveillance for 3 cancers, along with IgG4-related sclerosing cholangitis, which mimics both sclerosing cholangitis and cholangiocarcinoma, but responds to corticosteroids. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 2 of 3 of chapter 20, and I'll see you in the next one.